All right, so it's really an honor to be part of the speaker panel here today, and thank you all for coming out. I think it was a really good showing this morning, and we're all really impressed by that. A lot of the stuff that I covered, that I'm going to cover, has kind of been quickly covered in the previous lectures, but I'm going to kind of simplify it a little further and help you really understand Parkinson's disease. And of the two questions that I'm asked to address, what is Parkinson's disease and why did I get it, and I think probably more people want to know the answer to the second question than the first one. But we'll, the answer isn't all that exciting, but we'll talk about that a little later. When I think about Parkinson's disease, and I wonder, like Dr. Foote said, if everybody lived long enough, just with the normal degeneration of brain cells, just with the normal dying back of cells with aging, Parkinson's disease has probably been around for like ever. I mean, because people aged since people existed, right? So since the beginning, creation of humanity, that people were having Parkinson's disease when people got older. And I think for a long time, Parkinson's disease was described about a little less than 200 years ago by Dr. Parkinson, James Parkinson, who was a surgeon. And it was named after Dr. Parkinson a little while later by Dr. Charcot. But, before the description of Parkinson's, and even after the description of Parkinson's, a lot of people think that Parkinson's is part of normal aging. And if you think about the prototypical picture of a Parkinson's patient or an older patient, and if a comedian got on stage and he wanted to show you what an old man walks like, he would stoop his posture a little bit, bend forward a little, bring his feet closer together, and have a stick in the hand that's shaking, and he'd be shuffling. And that would be, that's a prototypical picture of a Parkinson's patient, but we've, come to understand that as being just normal aging. And for a long time, even having been described for almost 200 years, a lot of people still don't realize that's a sign of that, these are features of Parkinson's disease. And a lot of the people that I see in the clinic, and when I ask them, your parents, your grandparents, your great-grandparents, did they have Parkinson's or anything like that? It's hard to say, and they'll describe it for you, and they'll say, yeah, they walked a little funny, they walked, bent over a little bit, they had a cane, they were shaking, but I don't think they had Parkinson's, So, it's just that we don't put those things together, and we think that it's just part of normal aging. And so, what we're going to talk about, this actually, Dr. Foote stole that joke, so I'm not going to go over it again. The overview of our lecture is going to be those two basic questions. What's Parkinson's disease? We're going to talk about the symptoms, the causes, some of the causes, how does it start, how does it affect people, and why does it happen? And if I was to ask you a question, if I give you 4 clues about something, and if I asked you, this thing has 4 legs, a long muzzle, a tail, and it barks, what would you say it is? A dog, right? And if I said the word dog, you would think about dogs, right? But there are so many different kinds of dogs, right? Pointer doesn't really work on the TV, but they're all different kinds of dogs. But even though I said those 4 qualities, you thought of a dog, and probably everybody in here perhaps thought of a different picture of a dog. And dogs do differ, and apparently I'm not a big, keeper of domestic animals or pets or anything like that, but I'm told, or I read at least, that there are over 350 breeds of dogs, and I can be corrected if somebody knows better than that. I don't have a problem with that. And they're categorized into about 10 groups. And so, as you look at the pictures here, the dogs are clearly different, right? But they're all dogs. And so I want you to keep that in the back of your mind as we're talking about Parkinson's disease a little later. So Parkinson's disease is a progressive problem. In other words, once it starts, it just slowly gets worse over time. But, that seems to be one of probably the worst news. And when you talk about a progressive disease, people are like, oh, progressive, oh no. Because when you say a progressive disease or a chronic neurodegenerative disease, people think about what? Alzheimer's disease? People think about ALS, Lou Gehrig's disease. And the reason Parkinson's is so much different, is so different from those diseases is because there's treatment for Parkinson's. Now, it's true that there's no cure for Parkinson's, but there's treatment. Now, Parkinson's patients, they get Parkinson's and they'll live with Parkinson's for 10, 20, 30 years. And many even eventually die of unrelated cause. just like those people without Parkinson's dying of a stroke or a heart attack or getting hit by a car, your garden variety death, that can happen to Parkinson's patients as well. And many of them are unaffected at time of death by their Parkinson's. And progression, just like aging, and I'm sure you've seen people who are 50 years old and they look like they're 90, right? And there are people who are like 90 and they look like they're 50, and you're like, wow, you look great. And just like aging differs that way, the progression of the disease also differs. Now, no two people who are exactly the same age have the disease for the exact duration will have the exact same symptoms. It's not, I mean, you would have to go through thousands of patients to find two people of the same age at the same duration who have exactly all the same symptoms of Parkinson's. And we're going to talk about the symptoms of Parkinson's, and you're going to see that it's a whole list to choose from. And you get one or two or three or several of each kind. And so Parkinson's is a chronic condition. Now there's other chronic conditions that we know of, like diabetes, of hypertension. And the thing with those is they're not necessarily progressive. They're not neurodegenerative, but they're chronic. And in diabetes, the problem happens to be with a compound called insulin. Everybody knows insulin, but a lot of people don't know that, or may not know, that the problem in the chronic condition of Parkinson's is in a chemical called dopamine. So when you think about diabetes, think about an insulin problem. When you think about Parkinson's, you think about a dopamine problem. This chemical dopamine is contained in these cells in the brain that begin to die back. And just like we talked about dying back of cells with normal aging, right? Everybody ages, their brain shrinks, just normal aging. And other changes happen. The face starts to wrinkle up a little. They get more wrinkles than they did when they were younger. Muscles shrivel up a little. Just part of normal aging. And so this dying back of these particular cells is a pathological thing. In other words, it's more than normal aging. Okay. And it happens for an unknown reason. Now, there are a lot of hypotheses why it happens. Research, oxidative stress, is it mitochondrial stress? There are a lot of explanations of why this dying back of these cells happen, but there isn't that one clear, definitive reason. And even if those mechanisms are correct, why did they start in the first place? So we don't definitively know the answer to that question. And this dying back of cells, it leads to basically an asymmetric onset of motor and non-motor problems. So keep that in mind. When we think about Parkinson's disease, we always think about the motor stuff, right? Somebody's shaking, somebody shuffling, through posture, and things of that sort. But keep in mind, there are motor as well as non-motor features of Parkinson's. And the motor features, and I like to begin all of them with S's. I feel that the non-medical community, patients and family members, find it easier to remember the S's of Parkinson's. So shaky, stiff, and slow. Shaky, stiff, and slow. The shakiness, the tremor, is usually predominantly a resting tremor. So if you're resting, sitting there watching TV, for example, or you're attending Mass or your religious services and you're just resting, that's predominantly when the tremor happens. It may happen when you're drinking some coffee or eating your food or whatnot, but it's predominantly a resting tremor. Now, the stiffness and slowness is different from stiffness and slowness of stiffness that you get with arthritis. It's different from the slowness that you get just with normal aging. And everybody says this. When I ask somebody, do you feel slower than you did 5-10 years ago? He says, yeah, of course, I'm older now. But that slowness that we're talking about is an asymmetric slowing. One side is usually a little slower than the other. And the other S's, so those are the three main ones, and if you have two of them, then we're thinking Parkinson's. If you have one of them, we're kind of thinking it. If you have two of them, then we're thinking it a little more. There's a little more support for it. We're a little closer to the diagnosis of Parkinson's. And the other thing that support the diagnosis of Parkinson's is the company that those three S's keep, and these are also the more S's of Parkinson's. And those include stability problems through posture, shuffling gait, stutter step, or also a sticky feet. Basically, your foot gets stuck to the ground, you just can't get it up to go. Once it goes, then you're able to walk okay. Soft speech, swallowing difficulty, a straight face, right, expressionless face, small handwriting, spasms and cramps that may occur in your lower extremities or upper extremities. So those are the most of the motor features of Parkinson's. And the non-motor features, I'm just going to gloss over quickly. This is not it's a pretty thorough list, and I don't want you to just dwell on the words here. Just keep it in the back of your mind that people with Parkinson's disease may get mood or memory problems. So, mood like anxiety or depression, may have some behavioral changes, may have some memory problems. And some people, and keep this in mind, now, not every single patient is going to get everything that's up here. So don't look at this list and say, oh my God, that's what I have to look forward to. No, that's not true. In fact, I'm not sure if you heard about the man who told his friend, my wife got diagnosed with Parkinson's and she has horrible memory. And his friend goes, why? Does she forget everything? He says, no, she remembers everything. So it doesn't happen in everybody. So keep that. And sometimes I don't think it improves for sure, but it may be an unrelated thing. So sleep problems can happen. People unable to fall asleep, people unable to stay asleep, movement while you're sleeping, thrashing in bed, punching, kicking. So it's important to get that kind of history from your spouse if they wake up with a black eye or something like that. People moving their legs or their extremities before they fall asleep when they're resting, excessive daytime sleepiness. And there are other features like the autonomic system, and Dr. Foote kind of talked about that briefly. The autonomic system, think about it as the automatic system. Okay, things that you don't think about, they're just on autopilot. Like your heart rate right now, you're not controlling it, right? Your blood pressure right now, the temperature of your body, the fact that you're digesting the bagel that you had this morning. So those are all, parts of the autonomic or the automatic system. Making urine or holding it back your urine, right? You're not focused on, retaining that urine right now. You're focused on other things, and your same thing goes for the stools and digestion. And some of those things may be impaired in Parkinson's. The most common one happens to be constipation. And I think constipation happens to be very common in general, but obviously definitely more common in Parkinson's patients. And urgency or frequency of urine, and sometimes incontinence. Sometimes there could be low blood pressure, which will lead to lightheadedness, and some sensory problems as well, like smell dysfunction. And there's actually I have a joke for that, but save it till later. There's abnormal sensations that can be felt in the body: pain sensation, tingling, stiffness, and achiness. So the onset of Parkinson's is usually very gradual. And you can imagine if somebody had a little tremor, they're a little shaky, the first thing we think about is, it must be some anxiety, right? Especially if you notice in front of other people, you're like, oh no, it was the stress and I was meeting this person for the first time. So we think it could be a lot of other things, and we try to relate it to something else. And the stiffness, for example. I mean, usually in the older population, who doesn't have a little stiffness, right? Who doesn't have a little arthritis? And so for several years here it says, for 2 to 5 years, a person may go undiagnosed. Because your primary care doctor is looking at your shoulder as an arthritic problem, is looking at the tremor as just anxiety or something like that. And it usually starts in the late 50s. Early 60s, and the symptoms do vary. So it's not everybody doesn't follow the textbook, unfortunately. So the diagnosis does become a little slightly difficult to make. And the genetics of it is largely sporadic. In other words, it just happens. It's not necessarily because of any hereditary or genetic component, but the risk, if you have a blood relative, and a lot of people want to know this. And when they get diagnosed with Parkinson's, what does that mean for my children, for my grandkids, and things of that sort? Just remember that the risk, if a blood relative has Parkinson's, your risk goes up about you're twice as likely to get Parkinson's. So it's not like 10 times as likely. It's not as it is in some other diseases, but it does increase, and you're twice as likely to get Parkinson's. So like we said in the picture of the dogs. Just like not all dogs are the same, right? We gave those 4 qualities of a dog, right? 4 legs, a long muzzle, it barks, and something else we said. It has a tail, right? So those are 4 qualities of a dog. Now, but the dogs differ, as we saw in the picture. And just like the dogs differ, Parkinson's also differs. There are different flavors, and some are typical, some are atypical, some have different qualities. And these combinations, the ones that we talked, actually the motor and the non-motor symptoms that we talked about, kind of make up, if you take some of those combinations of those symptoms and signs and some other features as well, sometimes eye problems and things of that sort, sometimes blood pressure measurements, If you take those and take them into account, and different combinations make up the different forms. And the typical one, or the most common, happens to be the typical kind of Parkinson's, or also called the idiopathic. Idiopathic basically means we don't know why it happened. And that's the most common type. And the atypical Parkinson's are the others, and there are several subtypes of those, and we're not going to talk about them now. And PSP, as you guys heard about this morning, is one of those atypical kinds. And there's secondary Parkinson's. In other words, there's something happened to you that caused the Parkinson's. And some of those implicated causes maybe some sort of chemicals, dental amalgam, herbicides like Agent Orange, as many of you may know about, head trauma, like, as in the case of like Muhammad Ali or other people, supposedly, industrial toxins, insecticides, pesticides, petroleum waste, well water, strokes can do it, some medications, exposure can do it. But this is largely, this makes up a very small percentage of patients with Parkinson's, all of these secondary causes. And it's really unclear, how many of us, have some exposure to pesticide or insecticide, or somebody who, herbicide or industrial toxin, or where we worked, or well water maybe not so much. But so many of these chemicals are just, in our environment, and we're not sure how much exposure is real exposure. Most of us have exposure to some sort of chemical, but which one is the most important, and how much exposure really makes up for true, exposure that leads to Parkinson's, we don't know. And so, if you have these motor and non-motor features, and you have the combination, and you come to a neurologist's office, we're going to take the next step. And the next step is as follows. In the case of, let's say you went up one Saturday morning in spring, and you woke up and it was raining, and you rubbed your eyes and it stopped raining, and the sun came out, and you wanted to mow your lawn. Right, and you go out to, you get the lawnmower, and you pull the string and you try to start it up, and it doesn't start, right? And you just step back and you look at it, and everything looks like it's in place. It's four wheels. Is the motor thing is sitting there. Nothing looks broken. What's the first thing you check?
Check
the gas, right? It's just a common sense kind of thing to do. You check the gas, and so if you put gas in it and you try to start it up again, and it starts. What do you think is the problem?
There's no gas.
There's no gas, right? Are you going to still take it to the repair shop to get it fixed? No. So the analogy I'm trying to make is that if you have the components of Parkinson's, and your experienced neurologist feels that you have the components of Parkinson's, what we're going to do is test you, right? We think something's broken, we're going to give you some gas, we're going to give you some medications in the office or to take home, and you try them. And if you get better, do you need any other, you don't need any other workup really, right? And we get some referrals, from other neurologists, from other places that, their outside neurologists who may not be so experienced with treating Parkinson's told them that, I'm not going to give you any medication right now, but I want you to get a brain scan to see if you have Parkinson's. So they come to our office, and after our evaluation, and after we give them some medication and they get better, and we're confident in our diagnosis, we tell them the exact opposite. And then we're going to give you medication, and we don't think you need a brain scan. And they're like, no, my other neurologist told me the exact opposite. Because the diagnosis of Parkinson's is really a clinical one. And we'll use the brain scan, the one that's, becoming more commonly available these days, the DAT scan. We'll use that only if we're really unsure of the diagnosis of Parkinson's. So, those things put together kind of make up the diagnosis of Parkinson's. So that's Parkinson's in a nutshell. And why did I get Parkinson's? And this is a lot of people ask this question, and unfortunately this is, if you look in question and answer books, some of them I guess are here on the table outside, and you look at books that are written for patients, and this is one of the questions that's most frequently asked is, why did I get this? What did I do? And the simple answer is that no one knows, right? You guys are not happy with that answer. No one knows. I mean, you thought you were going to come here and get the answer. And simply put, no one really knows why you got it. And it's just like anything else. It's like just like diabetes. It's just like some arthritis you can kind of figure out. But diabetes, hypertension, high blood pressure, things of that sort. Sometimes we don't know why it happened. But you're thinking, was it this? Was it that? Was it something that I did? And was it the car accident I got into? Was it when I was playing football when I was 15 years old? Was it that one time that I smoked pot? I mean, you're thinking, was it this or was it that? And again, simply put, nobody really knows if it was any of those things. And then you're thinking, could I have done something to avoid it? And the simple answer to that is probably not. We really don't know that you could have avoided, you could have done something to avoid this Parkinson's. And there, like I said, the secondary causes seem to be probably, with the DAT, with the brain scan now available, we're able to tell. I mean, we're able to differentiate between a secondary cause caused by either stroke or like medication. Some people go on medications like Haldol, Risperdal, and things of that sort. So we're able to differentiate that. And so if you have a long history of use of those medications and we have a DAT scan that's negative, then we're thinking that that's probably what you have is drug related. So in most of the cases, we're not able to figure out what it is that you could have avoided from getting to not get this Parkinson's disease. And really what we need to learn more about this disease and the mechanism of it. And we know a lot already, but there's still a lot more work that needs to be done trying to understand what it is that kicks off that degeneration, the dying back of those cells, and what keeps it, what makes it start, and then how it progresses. So that's, I know it's not a very satisfying answer, but it takes me into my next and my last slide, which is the final message of my talk. In addition to learning about Parkinson's, is that you want to stay positive. You want to stay positive, and I'm going to show you a picture of a T-shirt that one of my patients was wearing. Stay positive. PD is not like Alzheimer's and ALS and those diseases that really don't have a deep, any significant treatment that alters the course or even the symptoms of those diseases. Parkinson's is quite different from that. Like I said, patients live, maybe 10, 20, 30 years, and many die of unrelated causes of death. And exercising, and we didn't talk a lot about management and treatment of Parkinson's disease, but exercising is very important. Eating well, maintaining a good body weight, that's also important. Enjoy life. The most important thing, as Dr. Foote was mentioning, is that we want you to enjoy your life. And there are people that will come with like very fine tremor and very slight tremor, and they want to be treated for that. Now, some people come with their hands like shaking all over, but they're like, nah, it doesn't bother me. What's most important to us is what's important to you. If it doesn't bother you and you're able to do whatever you want to do, we'll leave it alone and we'll let you enjoy your life. And so when you talk to your doctor, talk to them about what the things are that are important to you. And sometimes doctors may be addressing things that are not as important to you. So keep that in your mind. Keep moving and you'll stay moving. So again, it kind of emphasizes the point of exercising and doing things. And that's the T-shirt that I was talking about that one of our patients was wearing. Nice try of Parkinson's, but I'm still here. And that's really going back to being positive and just looking at life as a glass half full rather than empty. And that's pretty much it. Thank you.